Howdy, y'all. I'm Dr. Jeff Jarvis. Let's talk symptomatic bradycardia. Bradycardia is a challenge because it can lead to hypotension, syncope, and even cardiac arrest. These things are bad. Now, a quick physiologic reminder here. Blood pressure is a function of cardiac output and systemic vascular resistance. Cardiac output, it's the product of stroke volume times heart rate. Stroke volume is the amount of blood ejected from the left ventricle with each contraction. And that means even with normal volumes, normal stroke volumes, bradycardia can lead to decreased cardiac output solely by the rate. Low cardiac output, even with normal vascular resistance, leads to hypotension. Now, this is important to understand because the whole reason we care about bradycardia is because of its impact on cardiac output and blood pressure. This is a long way of saying if the blood pressure is okay, that means the bradycardia isn't causing the problem. If there's no hypotension, we're looking at stable bradycardia. That means no pacey, no pressors. Those are stable bradycardias. Just to be clear, we don't treat stable bradycardias with pacing or electricity. We only treat bradycardias with pacing or electricity if there's shock or hypotension. Now, we may need to prepare to treat if needed by placing pacing pads or drawing up medications, but we only need to start pacing or give the epi or the atropine if there is hypotension. Now, with that said, there are some other conditions that can lead to bradycardia, and we need to treat these before there is hypotension. Hyperkalemia is a good example. We should always consider the underlying cause of the bradycardias. Now, the differential for bradycardia may include myocardial ischemia, hypoxia, hyperkalemia, and overdose, both intentional overdose and unintentional overdose. If the patient's hypoxic and you correct the hypoxia, the bradycardia ought to improve. If it doesn't, keep looking for another cause. Toxidromes. Some toxidromes, particularly those that cause sodium channel blockade, things like tricyclic antidepressants, those can cause wide complex rhythms that can eventually progress to bradycardias. Typically, these are peri-arrest agonal rhythms. So, if you see these wide complex bradycardias, think toxicology and take a look at the toxicology protocol if this is what you're worried about. Now, in terms of treatment, for basics, as always, get a good history focused on identifying any potential causes. Get a 12-lead ECG and look for a STEMI. Hand that sucker off to the incoming paramedic crew to look for heart blocks or hyperkalemia or signs of toxicologic disease and treat accordingly if you find it. For ALS and advanced clinicians, in addition to pacing and atropine, there are some specific treatments based on suspected cause and age group. And don't forget the circulatory support protocol that authorizes IV fluids or pressors as you need them. For prepubescent children, start CPR even in the presence of a pulse if the heart rate is under 60 and there's hypoperfusion. For other pediatric patients, start with epinephrine instead of pacing. You can also try some atropine if the epi doesn't work, and then try pacing. Epi is very effective for pediatric bradycardia, so it's going to be pretty rare that it doesn't work and you need to try something else. Now, as with all pediatric drugs, don't try to memorize them, just look the dose up. God knows I mess them up all the time. We just don't use them enough to try to memorize them. For adults, go with pacing first and then try atropine if the pacing fails to capture. Atropine, by the way, is unlikely to work on a complete heart block that has a wide QRS complex. That wide QRS complex indicates the ventricular escape pacemaker. Remember that the top two chambers, the SA node, the AV node, that is completely isolated from the ventricle, henceforth complete heart block. The ventricular escape pacemaker, where it is in the system, indicates or drives how wide the QRS complex is. Remember, the width of the QRS is a function of how rapidly the ventricles depolarize. If they're depolarizing rapidly and you have a narrow QRS, that ventricular escape pacemaker is probably high up in the ventricle around that normal conduction system. And it turns out that that area actually does have some innervation by the vagus nerve. Vagus nerve delivers parasympathetic I'm going to try this again. The vagus nerve innervates the heart with parasympathetic stimulation. That's what I was trying to say. And parasympathetic stimulation is blocked by atropine. Atropine only works if there's parasympathetic blockade. Okay. Hopefully we got all of that out of the way. So you're going to go ahead and pace. Start at 30 milliamps and 70 beats per minute. Gradually increase that amperage until you get both electrical and mechanical capture. Now make this distinction because electrical capture is where you get the nice big bumps on the EKG. That looks great, but you may not have a pulse, and the pulse is what we need. Mechanical capture, on the other hand, is where you're generating the pulse, so you need both. Now, once you have obtained both mechanical and electrical capture, you can bump that heart rate up if you don't improve pressure. Now, don't delay pacing to start an IV. Pacing is certainly uncomfortable, but it typically becomes more tolerable with time. If you do need sedation, consider ketamine at either an IM injection or an infusion. And take a look at the pacing procedure for more information. Now, we mentioned some other causes. Let's think about hyperkalemia and overdose. Think about hyperkalemia in patients who have dialysis and they've missed a treatment, or with patients with chronic kidney disease, including those who aren't yet on dialysis, or maybe in patients with reasons to have acute kidney failure, such as they've had profuse vomiting or diarrhea and they got volume depleted. Look for it in those patients. Now, some of the ECG findings for hyperkalemia to look for are things like peaked T waves, really tall peaked T waves, wide complex QRS complexes, or sine wave looking things. If you see that, the treatment is calcium, and there was one other. Yeah, that's right, calcium. Now, calcium is interesting. It's another nice test for your new hires. Calcium doesn't actually directly lower potassium levels, but it does decrease the impact of hyperkalemia on cardiac depolarization, and that makes dysrhythmias, the things that we're worried about, less likely. Finally, if you think the patient is acidotic for other reasons, then give sodium bicarbonate. Now, from a toxicity standpoint, both calcium channel blockers and beta blockers, whether you accidentally took too many or you intentionally took too many, these can lead to hemodynamically significant bradycardias, and they are difficult to differentiate without knowing what they took. And that's why getting a good history is so critically important. Now, there is one thing that might help you tell them apart, and that's blood glucose. Hyperglycemia is more likely with calcium channel blocker toxicity, while hypoglycemia is more likely with beta blocker toxicity. Now, I don't know how often you're going to see that, so please don't hang your diagnostic hat on it. If you suspect a calcium channel blockade, this is going to be a shocker. Calcium channel blockade, maybe we should give calcium. Good plan, give calcium. For beta blockers, try glucagon. Really cool reasons that involve second messenger systems dealing with cyclic AMP. If you're interested, ask me more and I'll give you more, but for beta blockers, give glucagon. If that doesn't work, then go to an epi infusion rather than a norepi one, because it more directly impacts the problem, that is the low rate. Norepinephrine is all about peripheral vasoconstriction. Epinephrine, while it still has those alpha-mediated vasoconstriction effects, it also hits your beta-1 receptors and directly increases heart rate. Now, with either one, calcium channel blockers or beta blocker toxicity, remember push-dose epi is available and you can use it if you need it. Now, one last thing about pacing. If you have capture, please be careful at turnover in the emergency department. Well-meaning ED staff have been known to pull off actively pacing pads. They're trying to work quickly to help this patient, but inadvertently they rip the pacing pads off, and that can be really bad because they may not be able to obtain capture again. Now, best practice for this situation, this is how we should do the turnover. Clearly announce to everybody in the room that the patient is dependent on pacing.
Ladies and gentlemen, can I please have your attention?
Please don't rip off the pads.
And I need all of you to stop what you're doing and listen.
Because that could be bad. Then the way to do it appropriately is move the patient over to the ED while pacing with our monitor. Go ahead and put the ED pads on the patient and gradually increase the amperage on the ED machine and go up above what the amperage is on our machine. Then, once you've done that, gradually lower the amperage on our monitor while you're making sure that we still have capture. Once the amperage on the EMS monitor is all the way down and you still have ongoing capture with the ED monitor, then it's safe to go ahead and remove our pads. So that's it for the Bradycardia protocol review. Thank you for watching, and as always, thank you for what you do for our community every day. Take care, y'all.